from 2005 onward. I remember when our chief exec and our local council first shared this story with our staff, it resonated through the whole system. Everyone said, yes, we identify Mrs. Smith, we know who she is, and we want to make sure that she's well looked after. So where did we start once we had this vision? We knew who we were caring for. First thing we did was we talked to our population. We went out and talked to the people of the Bay and said, what do you want? You currently have a social care system and you have a health system, you have social services, you have your district nurses and OTs and physios and your GPs. What is it that you want? And these are the things they told us. And they're not rocket science. I'm sure they're things that we all recognize and would certainly have in all our systems, but they really wanted a single point of contact. Mrs. Smith didn't want to ring one number for the nurses, one number for the GP, one number for social services, a number for her domiciliary care provider. She wanted one number because it was getting very confusing what the list of numbers were for and who to contact, in particular out of hours as well. She wanted responsive services. When she had the need, she wanted it now. When she had that need met now, she didn't want to wait a long time. And she wanted to tell her story once. And also, she wanted all the various care professionals who were involved in her care to talk to each other so that she wasn't repeating the story, but also that they knew and they could share that information and make the best decision for her. Very simple stuff. So we built, and I will apologize for the next picture, it's pixelated because the IT has moved on quite substantially in the last 8 years, but our vision is still the same. This was the original picture, the image that we used when we communicated this to our stakeholders, to our staff, to our commissioners and everyone, that actually what we were trying to achieve was we had Mrs. Smith at the centre, and at the moment she was accessing her GP, seeing her practice nurse. Perhaps a community nurse would come in and help her with a dressing if she had a leg ulcer. She would go to see her acute consultants in the hospital, had some domiciliary care, which the social worker arranged, all those different parts of her care. And all she wanted to do was bring those together. And that's all we were aspiring to do, to make sure that there was a single assessment process run by an integrated team, and that's integrated amongst all the professions, not just health and social care, but everyone together, that linked in with the specialist services where required, and supported her and her family and friends to do the best thing for her in her care. As I said, you can see the IT's moved on quite substantially since this picture was created, but it's powerful nevertheless. So we went along and had a very person-centered approach. As I said, we had a Mrs. Smith vision, and we kept that message very clear and very simple, because it needed to be in language that everyone could understand, whether we were talking to staff, or whether we were talking to the population, whether we were talking to councillors or others. It was language that we all needed to identify with. And what was really important is when we brought those teams together, social workers and health staff and others, into co-located and integrated teams, the use of patient stories, whether you call them, we'll get into whether they're patients, service users, clients, others, was really important, because that's quite powerful. And to allow the teams to tell each other those stories as well really demonstrated what we were trying to achieve. And also, in bringing the teams together, we wanted to understand what added value to Mrs. Smith. There are things that we do on a day-to-day business, whether it's forms we fill in or phone calls we make or things we have to record, that add no value whatsoever to the individual. They don't care if we've got to go through 6 different steps to put their package of care in place. So we tried to reduce the steps that we were taking that didn't add value to Mrs. Smith. And most importantly, we engaged with frontline teams. We allowed them to shape the way that they work to achieve those outcomes within clear objectives. So what did that lead us to? We call it the community service model. So we have zone teams based around GP practices. So for example, in Brixham, we have 3 GP practices, a zone team that supports a population of about 25,000 people, quite a small contained zone, but Brixham is geographically, it has its own boundaries, so it made logical sense to do so. Whereas in Torquay, we actually have 2 zones, and Torquay South is our largest one in Torbay, which cares for a population of about 55,000. And more recently in Newton Abbot as well, which is about 55 to, it might be 58 by now. So varying population sizes, but depending on how the natural groupings of the GP practices best worked. Each of these local zones, we call them zone teams, has a single point of contact. So there's a one number that everyone has to ring, public or professional, just one number. And that goes to a health and social care coordinator. And I'll tell you a bit about them in a minute, but it's a special role we developed in the organisation that allows all those referrals to come in and they talk to the professions and sort whatever needs to be done right away. It falls under a general management structure. You've got one manager responsible for health and social care for that local population, and it's supported by, we've got professional practice leadership. So it's a matrix structure because obviously the manager can't be head of OT and head of nursing and head of social care all at the same time. So they're supported across the organisation by we have one head of nursing, one head of OT, and they support the manager where professional practice issues arise. The teams are all co-located. So they share an office and share, tea and coffee making facilities and everything. And I remember the day when the nurses wanted their own cupboard and the social workers wanted their own cupboard and who was paying for what milk. And we thought, no, we're going to get rid of all that. We co-locate teams together under one set of terms and conditions, one set of employment, and make sure that everyone adheres to the same way of working. And most importantly, as an organisation, we made sure that making the right thing to do, the easiest thing to do, because if the easiest thing to do is to ring 999, then that's what people will do, and then people will go into hospital. Or if the easiest thing to do is to put someone into a nursing or residential home placement, then that's the way the system will behave. However, if making the right thing is also the easiest thing to do, then you start to see, if you incentivise the way people work, you start to see that behaviour and that trend reverse. Unfortunately, in 2007 and 2008, we had the benefit of being able to invest some of our funds into intermediate care, which we now provide and have been for several years on a 7-day-a-week basis, although the weekend provision is a reduced capacity. And that is both for prevention of hospital admissions and to facilitate discharge. So in the broadest sense of intermediate care. And it's multidisciplinary. It's not therapy-led. Yes, it has a large proportion of therapy involvement, but we have social care input to it, nursing input to it, GP cover as well. And we engage our independent sector providers. So we spot purchase nursing and residential home beds if someone can't be supported at home under intermediate care. I've relayed most of this, but our operational characteristics, so a zone has a single community, the whole organisation has a single community health and social care record. This is where we get into the IT thing. We didn't have it from day one. In 2005, we didn't have a single community care record. We didn't actually have that until 2009. So for the first few years, we had to do, I think it was my predecessor in this talk sort of said, you do what you can. I remember very clearly they were having to lay out all the referrals that were printed out, and the nurses would have to check the social care referrals to see, oh, you're going in, well, then I'll go in with you, or, some of that dialogue did happen. But we used, in effect, the old social care system, Paris we have, and adapted it. We built what's called the health extension onto it. So we now have, in Torbay, a single health and social care record. So if I log onto someone's record, I can see everyone's involvement, everyone's input into the same record. It is a multidisciplinary assessment, not a social care assessment, not a nursing assessment. It's an MDT assessment that is done. As I said, we have single management. We have pooled health and social care budgets, and I'll reflect on some of that and some of the challenges more recent we have around that. So as a general manager, when I, for example, managed Torquay North and then Torquay South, I had a population budget for health and social care. And that way, you weren't making that decision on whether the TED stockings and eye drops are health or social care funded. I'm sure these are issues that everyone experiences on a day-to-day basis. That is the need that needs to be met, and you sort out the finances on an aggregate behind the scenes. Most importantly, decision-making's moved to the front line as well. If you have layers and layers of decision-making for approvals of packages of care, that creates a bureaucracy that adds no value to Mrs. Smith. Generally, the people, if you trust your professionals, the people who know best what assessment is the right one and what care is needed are your frontline teams. So to empower them to make the right decision with a performance focus, give them the performance metrics, share them, allow them to take ownership of the performance of the team. That will create the right behaviour. We also have access to our GP records in all our zones. So we have a shared information agreement with our GP practices. So again, in the interest of sharing information to make the right decision for an individual. And as I said, we introduced health and social care coordinators, not only in the zones, but in 2009, based on a pilot, we now have 7 of our acute wards staffed by our health and social care coordinators, working on the wards that from the point of admission, someone's care is planned for, so that when they go home on time with the right package of care, and they have access to all our community information on those wards as well. And we also have something called yellow folders for the most vulnerable to allow our independent sector providers to have access to that information as well. Just briefly, a bit about the health and social care coordinator role. As I said, they deal with all the focal points of referrals to the zone team, and basically the call comes in. Either it's something they can deal with themselves. When's my nurse coming to visit? I don't know what's going on. I need help. And they do an initial assessment. And actually, an audit a while ago, about 45% of the work that comes into that number is a one and done. It's something that they can deal with right then and there. They're NHS Band 5 level staff. They're qualified to NVQ4 in health and social care, so they are both health and social care coordinators. And that way, only those referrals that need to go to your OTs, to your physios, to your social workers go. So actually they have an opportunity to deal with relatively low or simple requests. And they also have the ability to set up simple packages of care and put an equipment in place right away without the need for lengthy assessments. And that led us to move from a process like this, which is what we had when it was old social services, so to speak, where a GP or a district nurse would identify a social care need, make a referral to social services, it goes to a coordinator who then takes it to the manager allocates it to a care manager, the care manager then goes in and makes an assessment, then goes back to the manager for approval or authorization of some expenditure, then liaises with either the home or a care manager, and then brokers the package of care. So there was a 7-step process many of you will recognize as a social care mechanism to this. So especially for a simple package of care, the GP or district nurse would ring the HSCC, they would assess the situation either on the phone or in person and broker the package of care, one and done. There was no allocation, referral, it was dealt that way. It's a simplification, but it gets the sense and the gist of it. And there were many other examples of the way we worked in nursing or therapies or others where we just streamlined it like that because we devolved that the decision-making and the ability to work together to meet the needs of the population right to the front line. Now, this didn't happen without system-wide leadership, and I cannot emphasize this enough, and I know you've heard this in other speakers this morning. The whole system needed to buy into this. We needed a shared vision, so we called that right care, right time, right place. And you needed a spirit of collaboration and cooperation amongst the council and the PCT and the acute hospital. We had a group where the chief execs all met very regularly to unblock those obstacles very early on of all the various stakeholders. And it was called Getting Patients Treated at the time. It's now called Joined Up Cabinet, which is a system-wide health and care community leadership group. And what was important is that everyone understood the system and its relationships and how changes in one part of the system will have impact, and all agreed to share the changes, and whether that meant good or bad things for their individual organizations. Some would win and some would lose. If it was the right thing for our population, everyone was signed up to do that. And symptoms of this were like putting people on a shared leadership training program, so that system leaders, whether it's hospital consultants or it's our senior managers in social care or other parts of the system, all were put on the same sort of development program and started to bring together those relationships outside of the workplace. We also had a system-wide approach to quality, so taking some of the things, for example, safeguarding. We had a big overhaul in safeguarding, and we made sure that that was everyone's business. And just to touch on comms, communication strategy was really important. We needed to make sure that we shared what we were doing at every opportunity possible. We piloted this model. We started in Brixham. We started small and then built on it. So we didn't try and change the whole organisation in one go, because if we tried to do that and if we tried to iron out any issue in advance, we'd still be talking about it and we wouldn't have got on and done. You just need to get on and do in some cases. And we are making a difference. I've relayed here some of the system measures that we've seen. We have the lowest excess bed days in the southwest. We have the lowest delayed discharges on record. We have a huge reduction in care home placements in Torbay, supporting a vast number of carers, lowest length of stay in our hospital in the country. Our urgent community equipment. If you need an urgent piece of equipment to get home, you can have it in 72 minutes is the average. It's very responsive. And the average life expectancy of our learning disabilities clients has increased by 8 years because of the multidisciplinary involvement. And we have the lowest percentage of hospital rates of death in the country. Now, what I would say is we didn't set out to change those individual measures. Those are measures that are set by the Department of Health or Social Services or others. We set out to do the right thing for Mrs. Smith. And over 8 years, the system caught up because actually then things started to happen in the right way. If you start to improve a single performance metric, you will find that you start to disincentivize behavior in the rest of the system. If you try and do the right thing for the population, you might find that the rest of the measures tend to fall into place. Just briefly before we go to questions, reflect that actually that hasn't just been in Torbay. In 2011, we took on the services in southern Devon, which has a different model of care because the social care responsibility is still with Devon County Council, not us, but the teams are under an integrated management structure. So we piloted what we called the Test to Change in partnership with Devon County Council by introducing that single point of contact and that care coordination in southern Devon zones. And that's seen huge successes. We've seen response times improve, we've seen care home placements go down, we've seen better utilisation in southern Devon in the community hospitals. The average length of stay has gone from 20 days down to 14. And all those similar performance metrics are now starting to happen in southern Devon as well. And we're taking that learning to see, okay, well, what can we learn from those tests to change to see what the key ingredients are that you need to have in an integrated model when you don't have all the levers within your system. We've also had the benefit of Section 256 monies in southern Devon to invest in community alternatives, which is really important to avoid this bed-based care. I'll skip over this just because in the interest of time, I can see my colleague hovering with the microphone. This is just a slide to show care home placements over time. The top you can see, year on year, we've reduced in Torbay care home placements by 5%. We went from one of the worst performing authorities back in 2006, where we had 1,250 care home placements, down to 750 now. We're in the top 10% of keeping people at home. And in southern Devon, the reason why I showed you the bottom table is that same behaviour is now happening in southern Devon. The time frames you can't see there start when we started the Test to Change. So in early 2012 is when we started measuring it, so you can start to see consistently they're coming down as well. Challenges for integration, I can't say it's easy, but the NHS reforms have made it more difficult to persevere an integrated model. You know, we now have clinical commissioners and a local authority where the risk sharing agreement around social care budgets have changed slightly. So we don't have those pooled commissioning arrangements anymore. We used to, as a PCT, be responsible for all the commissioning. Now it's gone to health and social care in different areas. System measurement, as I indicated, measuring the right things in the system continues to be a problem because as soon as you start measuring a certain thing, that's when it incentivizes behavior. And most importantly for us, how do you shape the independent and voluntary sector to be able to support more people at home, closer to home, as independently as possible? And that's not easy in a difficult economic climate. Final slide, we will continue to focus on Mrs. Smith. Because of the NHS reforms, we are now in a situation where we have to become a foundation trust. It hasn't been a focus of ours recently, but now we do because the timeframes are set that we need to become a foundation trust because we are an NHS organisation, and we're doing that by looking for an acquisition partner. And in doing so, we're currently in a sort of procurement process for that with our local DGH, South Devon Health+Care. So our next step of integration is a vertically integrated model as well as horizontally integrated. And of course, we're adapting to the post-reform landscape and making sure that we utilise our community hospitals, that bed-based care, which is an expensive resource, in the best possible way. SCCR is single community care record, so we're developing a new IT system as well. So we have what we have at the moment, but is there more that we can do with it? Mobile working, all those sorts of things that we haven't got at the moment. And that's it. I know I've probably almost overrun my time, but if there are any questions, just one or two, I'd be more than happy to take them. And of course, you can contact me afterwards.
Before we decide how much time you have for questions, is Tom Frusher here, our next speaker?
Oh, yes,
he is. That's a huge relief to all of us. Good. Probably just one question then we have time for. Yeah, gentleman over there. Can we get the mic? And we'll have to keep it fairly short if we can.
Just say that's one of the best and most insightful presentations I've heard over the last couple of days, so thank you very much.
Thank you. Well, you've made my day.
Good. And I suppose just a word of caution from another economy that's tried to do integration of health and social care, Herefordshire, where the integration model they went for was ambitious and acute trust, community health services and social care, and it's going through a really sticky patch at the moment. So just on your second to last slide about looking for an acquisition partner with the acute trust, the cultural differences between acute care and community stroke social care, I think can't be underestimated, and you know, so many insights for me about the importance of shared vision and making sure everybody's got the same feelings about what success looks like, because the relationship in Herefordshire is going in the wrong direction at the moment.
That's a really helpful comment, thank you.
Yeah, thanks very much. We'll actually have, I think there are more questions, but I'm sure that Sonja will be happy to see you at lunchtime and answer them personally. Tom Frusher.
Thank you.